Today, we've learned so much globally in this sessions that doctors have spoken on in this summit regarding aging. And as I'm going to share, more than 40% of the world is in rural regions. That is outside urban development in terms of transportation, infrastructure, rural aging, hospitals, and of course, the most important is the government financial infrastructure that rural aging and rural regions are not privy to. We've all learned that, of course, aging is growing exponentially. And in countries where there is low income, it's the most prevalent that we need to speed the pace of getting the resources and the infrastructure to geriatric patient care, caregiving, etc. That is of urgency now. Rural aging is to exceed urban aging. Currently now, it already exceeds, but as we continue in the aging process, rural aging is going to be the most prevalent. Part of the issue of rural aging is that chronic and cognitive diseases have now replaced infectious diseases. We've already learned through biomedical to contain infectious diseases across the globe. However, chronic cognitive diseases are replacing them. And I'm talking about dialysis, I'm talking about diabetes and cognitive changes such as forms of dementia, which there are over 100 conditions and diseases that cause dementia. So these are now becoming more prevalent for our societies to manage. And as a result, specifically in rural aging, physicians, allied health professionals, we must learn and be trained and educated on how older adults and their physiological, their psychological, even their pharmacokinetics and dynamics change, especially with comorbidities. So we have to increase the training and understanding that is happening today. Unfortunately, where we are today, and I say this precursor that I never blame physicians, because we have a deficit globally of geriatricians and gerontologists, those that have the expertise and the academic understanding and knowledge of geriatric patient care. And that is understanding of aging, and not only aging, but aging with morbidities, with a level of dependency, with a level of dementia. So that aspect in and of itself is considered geriatric patient care beyond aging. Nowadays, 60-year-olds are incredibly active, 70-year-olds, 80-year-olds. I'm not talking about aging in general. We've moved beyond that. I'm talking about aging that has chronic and cognitive diseases such as dementia right now. So a geriatric patient for the rest of my talk. So there is a level of maturity that is happening in rural aging, and the lack of infrastructure in geriatric support. The last talk spoke of needing aging in place, looking at adult communities, looking at assisted living or memory care, having home support, having an increase in caregivers, um, all of this infrastructure, having access to medical resources. And again, in all echelons of government, we need rural financial support for these resources. Part of the division between rural and urban aging, I'm not an economist, but it's pretty plain. In urban areas, there is more ability for taxation, right, for governments. And so there's a higher return of investment with healthcare, transportation, technology. And in rural areas, we have farming, we have communities that provide what I consider the most important aspect of our well-being, and that's our nutrition, right? But they also provide a lot of technology and such that is out in rural areas. But the return on investment is not as high. So at all echelons of government, there is not a strong financial influx supporting geriatric patient care. And that's in all fields: audiology, respiratory, dental, medical, psychological, understanding the environment. Rural older adults possibly live miles and hours away from just basic medical and dental. So it's important to get the resources, get physicians the training and knowledge on understanding the specifics of geriatric care, not just aging, but geriatric patient care. In a study that I conducted 3 years ago, and then the Alzheimer's Association last year had exact numbers as myself, 90% of physicians are lacking the confidence to diagnose and treat dementia. 90%. If I went to a mechanic knowing that 90% of mechanics were unable to fully understand the workings of a car and fully understand how to fix a car, do you think that would be acceptable? No, it would not, right? We wouldn't have the confidence. We wouldn't even probably go to a mechanic. We would learn ourselves. Nowadays, older adults lack the confidence in medical community, in the systems, because the statistics are showing that we are not providing the foundation, the academic and educational foundation for our biomedical, our physicians, our psychological, all areas of geriatric patient care. This is the infrastructure. So focusing on this is ultimately important. Geography often determines longevity more than genetics. So rural aging in and of itself requires a higher amount of resources and structure. Obviously, in rural areas, provider shortages, and there's fragmented services. Physicians often carry multiple roles. They are often a social worker. They help with food scarcity. They help with transportation and social work. So we are not only our caregivers, but our rural providers are finding themselves burned out and not given the resources that they need. Telehealth has become very efficient today, and in rural areas around the globe, we need to get that technology to providers and caregivers and the infrastructure alike, let alone adults that are aging in place. We must get them the technology, um, and look at the food scarcity, the isolation. Rural providers often serve, as I noted, as multiple um, roles, and the caregiver support, as noted in the prior um, slides, um, that the caregiver support ratio right now in many countries looks decent. However, that number is decreasing. Across Europe, the ratio is 5 to 1. The highest in the globe is Slovakia with 9 to 1. And then Ireland and other parts of Europe and Asia, 8 to 1. And of course, in Africa, we're unable to really look at the caregiver support ratio because lack of data. However, suffice it to say that in Africa, adults 60 and older are moving from 75 million in the next 25 years to 235 million. That is our exponential aging growth. So as you can see, and Africa is a very high rural region and geography. So it's just a high importance of us to get a consortium and get teams out to set up geriatric patient care infrastructures. So let's move out of the red and into the blue and a little bit more positivity on what we can do today. So I focus on, in my work, comprehensive and integrative care models. And what does that mean? Integrative care includes biomedical, psychological, social approaches. We look at integrating pharmacology, physical therapy, all aspects of needed for that patient. So it's an integrative care. Physicians today lack the understanding of drug-on-drug interactions and secondary symptoms that often exacerbate dementia patients, even beyond what dementia causes as secondary symptoms. So we need the pharmacological input. We need the cardiology as not only for aging, but for geriatric patients specifically. We need a more complex and integrative model to do dementia assessments and treatments and management, and understanding how to give a higher quality of life to those. Oftentimes, when there is a dementia diagnosis, and specifically Alzheimer's, Alzheimer's comprises 75% of all dementia diagnoses. Now, that doesn't disclude the other 100 different types of conditions and diseases causing dementia, Parkinson's, vascular dementia, alcoholism, drug abuse, traumatic brain injury. There are many causes of dementia, and those cannot be discounted. And we need to support our providers in understanding the different components. Now, physicians cannot do everything, right? I mentioned we have more than a 400% deficit of geriatricians and gerontologists. So basically specialists that are focusing on geriatric patient care, understanding the complexities beyond normative aging. Okay, this is not normative aging. So integrative care begins to have a team approach for assessment. Now, if you're a provider, if you're a clinic, if you're a hospital, and you're looking at this right now, the first thing you're seeing is, how is this going to impact us financially? Well, it is going to. It is. Their scheduling is going to be impacted, finances, resources, staff. It's a whole different determination. But once we get, and what we're seeing is once we get these integrative care models in place and these team approaches, that we're actually reducing the financial burden, not only on the medical system, but also on caregivers themselves, on adult communities, on salaried or non-salaried caregivers. So it's very important. Additionally, collaboration across um, audiology, respiratory, psychological, dentistry, and medicine. We need to come together to assess that patient fully, and have more of a comprehensive view. The focus is on prevention, of course, and function and quality of life. That is hugely important. So when I look at an integrative model, going into places like Ghana or Nepal, the United States, Europe, globally, we're looking at biomedical, psychological, pharmaceutical, social, environmental. I would also add, I look at mobility and their conditions. Biomedical includes, what are they diagnosed with? What are their conditions, their morbidities, multimorbidities? Are they able to be mobile? What is their muscular ability? Do they have atrophy? Psychological, of course, is their cognitive ability, their stage of dementia. What are they diagnosed with? And their mental health. Often when there is a diagnosis of dementia, we forget about the mental health that this patient has experienced their entire life. So we're now understanding the complexities of mental health and dementia. And it is a unique approach, and the two cannot be combined into one for pharmaceutical approaches. We look at pharmaceutical. What are the drug-on-drug interactions? What is the titration? I mentioned before pharmacokinetics and dynamics. How are pharmaceuticals processed? How are they impaired with our physiological processes for geriatric patients uniquely? And how do we need to titrate that? How can we look at alternative measures and treatments? And then social environmental. We need to look at safety and minimize risk. And the type of care, how can we enhance care for both salaried and non-salaried? If it were up to me, I would say globally, one way to enhance caregiving, whether salaried or non-salaried, especially salaried, is to have it become a career, not a job. A career entails at least a year of academic learning, a year-long certification program, or 2-year associates. Have it become a career so that they're paid and compensated equally, and there's not a greater turnover, and they have the foundation and learning needed. That is what's needed today to prevent burnout. And we're beginning to move that way. So, geriatric assessment, comprehensive and integrative approach. We evaluate not only by doing a cognitive testing, an MMSE, and 15 minutes of, do you understand a clock? Do you understand present, past, and future tenses? We need to look at what they've been diagnosed, what prescriptions, what is their environment? Do they move? Are they sedentary? What are they eating? Right? We need to look at this comprehensive approach and integrate the providers accordingly. And we need to include caregivers in the care planning, since they are the number one person for understanding any deviations in care. And we need to adjust for social determinants of health. And in rural areas, that is very high in terms of transportation, access to resources, giving providers the training and knowledge of geriatric care, telehealth, technology, giving those that are aging in place not only a first aid kit, but a larger kit, including a blood pressure cuff, looking at if they need to give insulin, if they have diabetes and they need to give shots, giving them a greater resource to care for themselves. Part of the assessments in the approaches when I work with countries as Nepal or Ghana or the UK and Europe, including the United States, is I like to remember that as a provider and health professionals, we must adhere to our initial merits of justice, beneficence, and autonomy. And I don't take those lightly, and neither should anyone, including governments at all echelons, focusing on aging and reducing ageism, which happens automatically and without malice often, because, as I mentioned, when there is a diagnosis of dementia, oftentimes the medical system begins to say, well, here, this is basically a termination, a termination. This is an older patient. They have a terminal condition. So now we will give them pharmaceutical treatment, keep them safe, and good luck. That is what's happening across the globe today. I'm not making a farce of this. This is actually happening. So we need to make these changes. And we're starting to. I'm starting to see initiatives and funding, and hopefully legislatively that will continue. We need to let's look at justice. What does justice mean? Justice means that we treat all patients equally, that we learn and we have accessible interpreters for language, that we understand culture, that we include diversity. And beyond that, that we're also looking at providing them the highest quality of care and treatment. And what does that entail? That entails us to have a higher level of specialized training, a higher level of education and understanding geriatric care. And that includes the integrative and comprehensive approach I mentioned. We look at beneficence, goodness, right? That means that we are doing all we can. We will treat anyone as a provider and a health professional. But beyond that, we need to move beyond a diagnosis of dementia with the lens of ageism and a determination that there's not much more we can do. There is much, much more we can do. We need to begin to learn to communicate with older adults and meet them where they are and give them the quality of life where they are. In rural settings today, oftentimes older adults have a higher level of isolation. So they're looking towards their neighbors together to have this collective of understanding and knowledge to support each other with food scarcity, with their crops, with support in transportation to medical community. So we have to give them the tools and the resources needed, excuse me, to understand how to proceed. Currently in Nepal, we've been working with nurses training for geriatric patient care, providing them certification. I had the privilege of just training recently almost 50 nurses in Nepal. In Ghana, working with psychiatrics. I'm sorry, psychiatrists. It's very early here.
Dr.
Psychiatrists.
Dr.
Yes.
Andrea, please wrap up. Uh,
I'm sorry.
yeah, please be fast. Actually, next time over.
Yes, I understand that I started late.
Yeah.
So there are initiatives happening all over the globe today in looking at mobile clinics, aging in place hubs, and that's where we need to go. We also need to look at a model of healing and respect for cultures in their uniqueness and integrate their traditional remedies and treatments and follow up with understanding the cultural and building trust through cultural sensitivity. So, in wrapping up, we need to expand all echelons of government support, insurance, healthcare services, education, including dental and dementia services. We need to support rural providers in trainings and incentives and give them the integrative and comprehensive support. And we need to integrate rural regions in policies and public health planning today, which is so important. And technology and innovation, we have to step it up for rural follow-up care, telehealth, AI-based dementia screening tools, which is a new assessment, taking all the integrative and comprehensive approaches that I mentioned and putting them in an autonomous look for that patient. And lastly, we need to communicate. Communication is care. We must learn the language of Alzheimer's and begin to expand that to rural regions, looking at systems that listen before prescribing and provide the support. Compassion sustains what medicine begins. And then, of course, expanding the geriatric infrastructure with adult communities, caregivers, and telehealth if we need, and training the next generation so that that 400% deficit is lowered. And lastly, ensuring equitable care regardless of geography. In closing, I wanted to quote the Nobel laureate Pearl Buck, who talked about our society must make it right and possible for older adults not to fear the young. And I say the changes that happen and be deserted. It's a test of a civilization and the way that we care for the helpless members. And I say the vulnerable members of our society. This is a test of any country today. And I ask all countries, all regions to take this into account and add new avenues and approaches for caring for geriatric patients. Thank you.